Hematology, Hematopoesis 2, Production and Bone Marrow. Blood is made up of plasma, which contains 91.5% water, 7% proteins, and 1.5% of other solutes. The buffy coat, which is the white blood cell platelets, they consist of lymphocytes, granulocytes, monocytes, basophils, neutrophils, and eosinophils, and the red blood cells. Blood cells found in the peripheral or circulating blood are the neutrophil, eosinophil, basophil, monocyte, lymphocyte, red blood cells, and platelets. In the embryo, primitive cells or mesenchymal stem cells are first formed in the yolk sac. These cells differentiate into blood cells. During phase 1 of embryonic blood cell production, the mesoblastic phase occurs in the yolk sac. This includes the formation of blood islands that carry on fetal erythropoiesis. It occurs in the second and third month of gestation. The embryonic hemoglobins are Gower-2, Gower-1, and Portland. In phase 2 of blood cell production, the hepatic phase, the production of red blood cells occurs primarily in the liver, also the spleen and thymus and lymph nodes. The production of granulocytes and megakaryocytes begins. This occurs in the 4th and 5th months of gestation, and the hemoglobin is hemoglobin F, or fetal. In phase 3 of cell production, the myeloid phase, bone marrow takes over the cell production, or myelopoiesis. This occurs in the 5th month of gestation. Lymphocytes, including plasma cells, are produced in the lymph and spleen throughout life, or extramedullary production. Hemoglobin A, or adult hemoglobin, is produced 3 weeks postpartum. Shortly after birth, extramedullary production of red blood cells and granulocytes, such as neutrophils, monocytes, eosinophils, and basophils, ceases. After the bone marrow takes over production of blood cells, the primitive mesenchymal stem cells are reduced. They persist throughout life as part of the reticuloendothelial system. The reticuloendothelial system consists of the bone marrow, liver, spleen, and lymph nodes. The stem cells remain active in the bone marrow, but are inactive in other parts of the reticuloendothelial system. If needed, such as in cases of bone marrow damage or increased need of cell production, these dormant stem cells can become active and produce cells. This would be extramedullary hematopoiesis. Red marrow versus yellow marrow. During the first few years of life, the infant bone marrow space is limited, and all is used for cell production. In the infant, hematopoiesis occurs in the bone marrow of all bones. By the 4th year, the bone marrow growth exceeds the need for blood cells, and marrowcytes are replaced with fat cells. The amount of fat increases with age. By the age of 18, half is red and half is yellow. At 70, 2/3 is yellow and 1/3 is red. In the adult, hematopoiesis is confined to the bone marrow of the trunk, which includes the ribs, sternum, vertebrae, and pelvis, the skull, and proximal portion of the long bones, the humerus and femur. The red marrow contains the blood cells. The yellow marrow is dormant and contains fat. It's capable of reverting back to red marrow if needed. Bone marrow structure. Bone marrow is encased within the cavities of bone. Endosteum is the living membrane that lines the hollow bone cavity. Bone marrow consists of blood vessels, nerves, mature and immature blood cells, fat, and fibrous tissue. Hematopoiesis occurs in the sinuses of the bone marrow. Blood cells are formed and develop in the hematopoietic space of the bone marrow. When mature, they squeeze through the aperture or openings in the endothelial lining of the venous sinus. They enter the central vein and are transported to the peripheral blood or the blood in the vein. Bone marrow aspiration. Bone marrow aspirate is an invasive and potentially painful procedure. Technologist acts as an assistant. The technologist reviews the smear and determines if the aspirate is an acceptable specimen. The site of choice for bone marrow aspiration is the iliac crest. They use local anesthesia. Once the needle has seeded into the marrow, the syringe is placed on the end. Small amount of bloody fluid is attained. The technologist locates spicules from the specimen. The biopsy may be taken at this time. Bone marrow report. A physician will evaluate the bone marrow for overall cellularity, M/E ratio, maturation of each cell line, marrow to fat ratio, presence of abnormal or tumor cells, and Prussian blue stain can evaluate iron stores. Cell reproduction. Immature cells are capable of undergoing mitosis and producing two daughter cells that are exactly alike. All the offspring from one cell is a clone and are exactly alike. After a certain stage in development, the cells are too mature to undergo reproduction. They develop to the mature state. Growth factors. Cells are produced from the PSC based on need. Cell production is stimulated by growth factors or chemicals. Interleukins from lymphocytes, or IL-3, erythropoietin, or EPO, for erythrocytes, thrombopoietin, or TPO, for platelets, or thrombocytes, granulocyte, monocyte colony stimulating factor, or GM-CSF, for erythrocytes, granulocytes, and platelets, lymphocytes growth factors, or interleukin, IL-1, 2, 4, 6, and 7. Bone marrow cellularity. Determination of bone marrow cellularity gives information about the number of cells being produced by comparing the ratio of BM cells to fat. Nerves in the marrow space are probably sensitive to pressure and help regulate the number of cells produced in the bone marrow. Bone marrow cellularity count. When cell production increases, it increases pressure on the nerves, which may produce signals and auto-regulate or decrease the cell production. If cell production increases, fat production will decrease. If cell production decreases, the bone marrow will fill the empty space with fat cells. What happens if overproduction occurs? If the bone marrow becomes full of cells, cell production will decrease. Example: in leukemia, there is unregulated increased production of white blood cells. These crowd out the red blood cells and platelets, who in turn decrease their production. Myelofibrosis is a condition in which bone marrow is replaced by fibrous tissue. Chapter 2. From Hematopoesis to the complete blood count. Word key: acrocyanosis, blue or purple mottled discoloration of the fingers, toes, or nose, or all three. Angina pectoris, oppressive pain or pressure in the chest. Chemotherapy, drug therapy used to treat infections, cancers, and other diseases. Dyspnea, shortness of breath. Hepatosplenomegaly, enlargement of liver and spleen. Hyponatremia, decrease in sodium. Hypoxia, decreased oxygen. Myelotoxic, chemicals that destroy white blood cells. Palpitation, cessation of rapid or irregular beating of the heart. Postural hypotension, change in blood pressure from sitting to standing. Raynaud's syndrome, intermittent attacks of pallor and or cyanosis in extremities. Reticuloendothelial system, system of fixed macrophages and circulating monocytes that serve as phagocytes engulfing foreign substances. Syncope, fainting. Tachycardia, fast and hard heartbeat. Hematopoesis, the origin of cell development. Hematopoesis is defined as the production, development, differentiation, and maturation of all blood cells. Within these four functions is cellular machinery that outstrips most high-scale manufacturers in terms of production, quotas, customs, specifications, and quality of final product. When one considers that the bone marrow can produce 3 billion red blood cells, 1.5 billion white blood cells, and 2.5 billion platelets per day per body weight, the enormity of this task in terms of output is almost incomprehensible. Within the basic bone marrow structure lies the mechanisms to do the following: supply the peripheral circulation constantly with mature cells, mobilize the bone marrow to increase production if hematologic conditions warrant, compensate for decreased hematopoiesis within the bone marrow by recruiting other hematopoietic sites, such as non-bone marrow sites, liver, and spleen. The bone marrow is extremely versatile and serves the body well by supplying life-giving cells with a multiplicity of functions. Various organs serve a role in hematopoiesis, and these organs change as humans develop from a fetus to an adult. The yolk sac, liver, and spleen are the focal organs in fetal development. From 2 weeks to 2 months of fetal life, most erythropoiesis occurs in the fetal yolk sac. This period of development, known as the mesoblastic period, produces primitive erythroblasts and embryonic hemoglobins, such as hemoglobin Gower 1 and Gower 2, and hemoglobin Portland. These hemoglobins are constructed as tetramers, with 2 alpha chains combined with either epsilon or zeta chains. These embryonic hemoglobins do not survive into adult life or participate in oxygen delivery. During the hepatic period, which continues from 2 months through 7 months of fetal life, the liver and spleen take over the hematopoietic role. White blood cells and megakaryocytes begin to appear in small numbers. However, the liver serves primarily as an erythroid-producing organ and also gives rise to fetal hemoglobin, which consists of alpha and gamma chains. The spleen, thymus, and lymph nodes also become hematopoietically active during this stage, producing red blood cells and lymphocytes. From 7 months until birth, the bone marrow assumes the primary role in hematopoiesis, a role that continues into adult life. Additionally, hemoglobin A, which is the majority of adult hemoglobin, alpha 2, beta 2, begins to form. The full complement of hemoglobin A is not realized until 3 to 6 months postpartum, as gamma chains from hemoglobin F are diminished and beta chains increase. In a normal individual 6 months old or older, 95 to 98% of the total hemoglobin is hemoglobin A, 2 to 5% is hemoglobin A2, and less than 2% is hemoglobin F. Hematopoiesis within the bone marrow is termed intramedullary hematopoiesis. The term extramedullary hematopoiesis describes hematopoiesis outside the bone marrow environment, which in an adult is primarily in the liver and spleen. Because these organs play major roles in early fetal hematopoiesis, they retain their hematopoietic memory and capability and can function as organs of hematopoiesis if needed in adult life. Several circumstances within the bone marrow, such as infiltration of leukemic cells and tumors, may diminish the normal hematopoietic capacity of the bone marrow and force these organs to perform again as primary or fetal organs of hematopoiesis. Although extramedullary hematopoiesis is possible, it puts strain on the liver and spleen, and these organs often become enlarged, a condition known as hepatosplenomegaly. Physical evidence of hepatosplenomegaly manifests as an individual who looks puffy and protrusive in the left upper and slightly right upper abdominal area. Hepatosplenomegaly is an indicator that hematologic health is compromised. The spleen as an indicator organ of hematopoietic health. Few organs can match the versatility of the spleen. Traditionally, the spleen was considered an inconsequential organ, not necessary to life function. As an organ of the hematopoietic system, however, the spleen has immense capability and provides valuable functions. This small but forgotten organ is a powerhouse of prominent red blood cell activity, such as filtration, production, and cellular immunity. Under normal circumstances, the spleen cannot be felt or palpated on physical examination. Located on the left side of the body under the rib cage, the spleen is a fist-shaped organ that weighs about 8 ounces, is soft in texture, and receives 5% of the cardiac output per minute. The spleen is a blood-filled organ that consists of red pulp, white pulp, and the marginal zone. The function of the red pulp is primarily red blood cell filtration. The white pulp is involved in lymphocyte processing, and the marginal zone stores white blood cells and platelets. Functions of the spleen. There are 4 main tasks of the spleen that relate to red blood cell viability and the immunologic capability of the spleen. The first function is the reservoir, or storage, activity of the spleen. The spleen harbors 1/3 of the circulating mass of platelets and 1/3 of the granulocyte mass, and may be able to mobilize platelets into the peripheral circulation as necessary. In the event of splenic rupture or trauma, large numbers of platelets may be spilled into the peripheral circulation. This event may cause unwanted clotting events, as the platelets function as catalysts for hemostasis, the blood clotting system within peripheral circulation. The second function of the spleen is the filtration capacity. The spleen has a unique inspection mechanism and examines each red blood cell and platelet for abnormalities and inclusions. Older red blood cells may lose their elasticity and deformability in the last days of their 120-day lifespan and are culled from the circulation by splenic phagocytes. Bilirubin, iron, and globin byproducts released through this culling process are recycled through the plasma and circulation to be used to build new cells. Red blood cells that are filled with inclusions, such as Howell-Jolly bodies, Heinz bodies, Pappenheimer bodies, are selectively reviewed and cleared from the cells. Inclusions are pitted and pulled from the red blood cell without destroying the cellular integrity, and red blood cells are left to continue their journey through the circulation. Antibody-coated red blood cells have their antibodies removed and usually reappear in the peripheral circulation as spherocytes, a smaller, more compact red blood cell structure with a shortened lifespan. One of the least appreciated roles of the spleen is the immunologic role. As the largest secondary lymphoid organ, the spleen plays a valuable role in promoting phagocytic activity for encapsulated organisms such as Haemophilus influenzae, Streptococcus pneumoniae, or Neisseria meningitis. The spleen supplies opsonizing antibodies, substances that strip the capsule from the bacterial surface. When this is accomplished, the encapsulated bacteria are more vulnerable to the phagocytic reticuloendothelial system and less able to mount an infection to the host system. Without a functioning spleen, the RES would have a much harder time or even be unable to provide protection from these organisms, possibly leading to serious consequences, including fatality for the infected individual. Thus, the spleen is more than a hematopoietic organ. It is valuable to human health. Potential risks of splenectomy. Enlarged, infarcted, injured, or minimally functioning spleens can endanger patients, and often the spleen is removed in such situations. The spleen may be enlarged as a result of leukemic condition, or the spleen may be injured as a result of a fall or abdominal injury. In either of these situations, the vital functions of the spleen are compromised. The patient will suffer and usually bleed. Although the splenectomy procedure may provide hematologic benefit to patients who have problems with their spleen, individuals who do not have spleens have additional risks, as mentioned earlier. There have been reports in the literature of overwhelming post-splenectomy infections that may occur years after the spleen has been removed. In most cases, these infections occur within 3 years, but some have been reported 25 years after splenectomy. Many individuals die of OPSIs, or at the very least have multi-organ involvement because the spleen is not there to play its vital role in immunology and hematopoiesis. If the decision is made to remove the spleen, the surgeon should leave some splenic tissue in place so that some splenic function is preserved. Asplenic individuals represent a more vulnerable population and need to be carefully managed. Functions of the spleen. The spleen's hematopoietic function It can produce white blood cells, red blood cells, and platelets if necessary. Reservoir function. 1/3 of platelets and granulocytes are stored in the spleen. Filtration function. The spleen filters out of circulation any cells that are too old or have deformed membranes. Antibodies are removed from red blood cell membranes and inclusions are removed from red blood cells. The spleen presents a hostile environment for cells to circulate. Those that make it through have proved to be viable. Immunologic function. Opsonizing antibodies are produced, which allow phagocytosis of encapsulated organs. Bone marrow and myeloid-erythroid ratio. The bone marrow is one of the largest organs of the body, encompassing 3 to 6% of body weight and weighing 1,500 grams in an adult. It is hard to conceptualize the bone marrow as an organ because it is not a solid organ that one can touch, measure, or weigh easily. Bone marrow is composed of yellow marrow, red marrow, and an intricate supply of nutrients and blood vessels. Within this structure are erythroid cells, red blood cells, myeloid cells, or white blood cells, and megakaryocytes, or platelets, in various stages of maturation, along with osteoclasts, stroma, and fatty tissue. Once cells have matured in the bone marrow, mature cells pass through sinuses in the marrow to ensure the peripheral circulation. Bone marrow sinuses are lined with endothelial cells that provide passage for mature cells from extravascular sites to the circulation. In the first 18 years of life, bone marrow is spread throughout all the major bones of the skeleton, especially the long bones. As the body develops, the marrow is gradually replaced by fat until the prime locations for bone marrow in an adult become the iliac crest, located in the pelvic area, and the sternum, located in the chest area. The cause and effect of hematologic disease are usually rooted in the bone marrow because it serves as the central factory for production of all adult hematopoietic cells. In terms of cellularity, there is a unique ratio in the bone marrow termed the myeloid-erythroid ratio. This numerical designation provides an approximation of the myeloid elements in the marrow and their precursor cells, and the erythroid elements in the marrow and their precursor cells. A normal ratio of 3:1 to 4:1 reflects the relationship between production and lifespan of various cell types. White blood cells have a much shorter lifespan than red blood cells, 6 to 10 hours for neutrophils as opposed to 120 days for erythrocytes, and must be produced at a much higher rate for normal hematopoiesis. Alterations in myeloid-erythroid ratio. Factors that may impair red blood cell lifespan, inhibit overall production, or cause dramatic increases in a particular cell line cause a change in the M to E ratio, making it a good indicator of hematologic pathology. Many observations in the peripheral smear can be traced back to pathophysiologic events at the level of the bone marrow. A perfect example is the response of the bone marrow to anemia. As anemia develops, the kidney senses hypoxia as a result of decreased hemoglobin levels. Tissue hypoxia stimulates the kidney to release an increased level of erythropoietin, or EPO, a red blood cell stimulating hormone. EPO travels through the circulation and binds with a receptor on the youngest of bone marrow precursor cells, the pronormoblast. Bone marrow has the capacity to expand production 6 to 8 times in response to an anemic event. Consequently, the bone marrow increases production of red blood cells. When production is increased quickly, the bone marrow may release cells into the peripheral circulation that are less mature than normal. This results in immature red blood cells, such as reticulocytes and nucleated red blood cells, found in the peripheral circulation. What is observed in the peripheral blood smear is polychromasia, stressed reticulocytes, large polychromatophilic red blood cells, and nucleated red blood cells, both indicating that the bone marrow is regenerating in response to an event. Thus, the dynamic between the bone marrow and the peripheral circulation can be indicated by reviewing peripheral smears in the hematology lab. Red blood cell terminology. Several nomenclatures describe the maturation stages of the red blood cell. They're presented here because many textbooks use them interchangeably. There seems to be little advantage in using one terminology over the other. However, the original intent of creating the terminologies was to clarify the terms created in the 1800s describing red blood cell maturation and make the stages of maturation easier to remember and master. The College of American Pathologists uses the word blast in the description of maturation stages, whereas the American Society of Clinical Pathologists incorporates rubri into the first four maturation stages. CAP terminology is used throughout this textbook. Where CAP uses pronormoblast, ASCP uses rubriblast. Basophilic normoblast to prorubrocyte, polychromatophilic normoblast to rubrocyte, orthochromic normoblast to metarubrocyte, reticulocyte to reticulocyte, and erythrocyte to erythrocyte. Role of stem cells and cytokines. A unique feature of the bone marrow microenvironment is the presence of stem cells. Stem cells are multipotential, meaning they can differentiate into a variety of cells based on stimuli received from the body. They resemble lymphocytes and are available in the bone marrow in the ratio of one stem cell for every 1,000 non-stem cell elements. Stem cells were demonstrated in the classic experiment of Till and McCulloch in 1961. These investigators irradiated the spleens and bone marrows of mice, rendering them acellular, and then injected them with bone marrow cells. Within days, colonies appeared on the spleens of the mice and were referred to as colony-forming units, with cells capable of regenerating into mature hematopoietic cells. In present-day terminology, CFUS are more pluripotential stem cells. Multipotential stem cells are capable of differentiation into non-lymphoid or lymphoid precursor committed cells. Non-lymphoid committed cells can develop into a white blood cell, red blood cell, or megakaryocyte cell, a group known as the GEMM, granulocyte, erythroid, monocyte, and megakaryocyte family. Lymphocytic committed cells develop into T cells or B cells, which are of different origins. T cells are responsible for cellular immunity, or cell-to-cell communication, whereas B cells are responsible for humoral immunity, the production of circulating antibodies directed by plasma cells. Each of these committed cells evolves into its adult form through proliferation, differentiation, and maturation. Chemical signals such as cytokines and interleukins are uniquely responsible for promoting a specific lineage of cell. Most of these substances are glycoproteins that target specific cell stages. They control replication and clonal or lineage selection and are responsible for maturation rate and growth inhibition of stem cells. Many cytokines are now available as pharmaceutical products. Recombinant technology has made it possible to purify and produce cytokines such as interleukins, EPO, granulocyte colony stimulating factor, and granulocyte macrophage colony stimulating factor. These products are used to stimulate a specific cell production to yield therapeutic benefit for patients. Specific conditions in which recombinant cytokines have been useful include the following: recovery from neutropenia resulting from myelotoxic therapy, treatment of graft versus host disease after bone marrow transplant therapy, increasing white blood cell counts in patients with AIDS on antiretroviral therapy, and stimulating red blood cell production for chronically anemic patients and chemotherapy patients. Erythropoietin. Erythropoietin is a hormone cytokine produced by the kidneys that functions as a targeted erythroid growth factor. This hormone can stimulate red blood cell production through a receptor on the youngest red blood cell precursor in the bone marrow, known as the pronormoblast. EPO is secreted on a daily basis in small amounts and functions to regulate red blood cell production. In an anemic state, when hemoglobin levels decline, the kidney senses tissue hypoxia and secretes more EPO. Consequently, red blood cell production accelerates, and younger red blood cells are released prematurely. Complete red blood cell maturation from the pronormoblast stage normally takes 5 days. In accelerated erythropoiesis, maturation can decrease to 3 to 4 days. Human recombinant erythropoietin is available as a pharmaceutical product and can be used for individuals experiencing renal disease when the kidneys are unable to produce EPO. Individuals who have become anemic as a result of chemotherapy or individuals who refuse white blood cell products for religious reasons. Bone marrow analysis. Obtaining a bone marrow aspirate or biopsy specimen is an invasive and potentially painful procedure. For this reason, this procedure is carefully considered before proceeding. There are a few anemias for which a bone marrow procedure is necessary for diagnostic purposes. Diagnosing white blood cell disorders such as leukemia or lymphoma, however, relies on a baseline bone marrow evaluation. Bone marrow report. Bone marrow slides can be stained and evaluated for overall cellularity, MTE ratio, maturation of each cell line, marrow to fat ratio, and presence of abnormal or malignant cells. A Prussian blue stain can evaluate the bone marrow iron store. The marrow architecture is observed for abnormalities in the stromal structure, such as necrosis or fibrosis. Combined with the patient's complete blood count, these results enable the physician to diagnose what may be causing the anemic state. Complete blood count. The CBC is one of the most frequently ordered and most time-honored laboratory tests in the hematology lab. This evaluation consists of 9 components and offers the clinician various hematologic data that directly relate to the hematologic health of the patient. The 9 components of the CBC are the white blood cell count, the red blood cell count, hemoglobin, hematocrit, mean corpuscular volume or MCV, mean corpuscular hemoglobin or MCH, and mean corpuscular hemoglobin content, platelet count, and red blood cell distribution width. Depending on the type of automated instrumentation used, some of these parameters are read directly from the instrument and some are calculated. Generally, most automated instruments directly read the white blood cell, red blood cell, hemoglobin, and MCV, whereas the hematocrit is calculated. Correlation checks between the hemoglobin and hematocrit are a significant part of quality assurance for the CBC and are known as the rule of 3. Red blood cell times 3 equals hemoglobin. Hemoglobin times 3 equals hematocrit plus or minus 3. As a matter of practice, each operator of an automated hematology instrumentation should make a habit of quickly and accurately establishing a correlation check for each sample. Failure to fall within the correlation check is usually the first indicator of post-analytic error and may indicate corrective actions, such as reviewing a peripheral smear, tracing the origin of the samples, or other investigation. Additionally, each instrument presents a pictorial representation of the hematologic data registered as either a histogram or a scatter plot representing the distribution of cells. Many new automated instruments offer an automated reticulocyte count. Reticulocyte procedures are discussed in Chapter 21. Morphologic classification of anemias. Anemias are generally classified either morphologically or pathophysiologically. The pathophysiologic approach refers to the cause of anemias, whether by excessive destruction or diminished production of red blood cells. Although this is a respected approach, more clinicians are familiar with the morphologic classification of anemias that relies on the red blood cell indices, mean corpuscular volume, mean corpuscular hemoglobin, and mean corpuscular hemoglobin content. This classification is readily available using CBC data and can be acted on quickly to begin an investigation into cause. There are 3 morphologic classifications of anemia: normochromic normocytic anemia, microcytic hypochromic anemia, and macrocytic normochromic anemia. A normocytic normochromic anemia implies a normal red blood cell MCV and normal hemoglobin content of red blood cells. Although red blood cell and hemoglobin values may be reduced, the size and hemoglobin content per cell are in the normal range. Red blood cells are normal size with a normal hemoglobin content. A microcytic hyperchromic anemia implies MCV of less than 80 with MCHC of less than 32%. In this blood picture, the red blood cells are smaller and lack hemoglobin, having an area of central pallor much greater than the usual 3 micrometer area. A macrocytic normochromic anemia implies MCV of greater than 100. Red blood cells are larger than 8 micrometers, with hemoglobin content in the normal range. Automated results and peripheral smear findings should always correlate. For example, a patient sample with MCV of 67 and MCHC of 30% should have red blood cells that are small and pale. If the peripheral smear results do not correlate with the automated results, an investigation should be initiated to determine the cause of the discrepancy. A detailed explanation of anemias under each morphologic classification is provided in the subsequent chapters. Calculating red blood cell indices and their role in indicating sample integrity. The red blood cell indices provide information concerning the size and hemoglobin content of red blood cells. The MCV is one of the most stable parameters in the CBC, with little variability, less than 1% over time. For this reason, the MCV has an extremely valuable role in monitoring the pre-analytic and analytic qualities of the sample. The MCV either is directly read by instrumentation method or is a calculated value. If it is calculated, the formula is hematocrit divided by red blood cells times 10. The normal value is 80 to 100 and implies a red blood cell that has a size of 6 to 8 micrometers. Patient conditions that may cause a shift in this parameter include the presence of cold agglutinins, red blood cells coated with cold antibody causing a false increase in size, transfusion therapy or newly transfused cells are larger, and reticulocytosis, the presence of polychromatophilic macrocytes, immature red blood cells are larger than fully mature cells. Specimen or preanalytic factors that may account for shifting MCV include contamination by drawing through the IV lines or indwelling catheters, specimens from hyperglycemic patients, specimens from patients on some chemotherapy drugs or zidovudine therapy, or patients who are extremely dehydrated. Any shift in MCV that cannot be explained as a result of the previously listed circumstances should prompt the laboratory to investigate a possible sample mismatch or misidentification. For this reason, the MCV is highly valued as a delta check parameter for sample integrity. The MCH and MCHC provide information concerning red blood cell hemoglobin load. The MCH can be calculated by dividing the hemoglobin by the red blood cells and multiplying by 10. The normal MCH value is 27 to 31, which implies the average weight of hemoglobin in a given amount of red blood cells. The MCHC content can be calculated by dividing the hemoglobin by the hematocrit and multiplying by 100. The normal MCHC value is 32 to 36%, which implies that the average concentration of hemoglobin per volume of red blood cells is in the normal proportion. A normal set of red blood cell indices implies a red blood cell that is properly sized and a cell that has the proper amount of hemoglobin for a normal 120-day lifespan. The value of red blood cell distribution width. The eighth parameter of the CBC is the RDW, a mathematical calculation that gives insight into the amount of anisocytosis, or variation in size, and, to some degree, poikilocytosis, or variation in shape, in a peripheral smear. The RDW is the standard deviation of red blood cell volume divided by the mean MCV multiplied by 100. The normal value of RDW is 11.5 to 14.5%. The standard deviation of red blood cell volume is derived from the histogram plot that contains data on a large number of red blood cells and their various sizes. The RDW is useful because in many cases, RDW becomes abnormal earlier in the anemia process, whereas the MCV is not affected until later in the anemia process. Because many anemias, such as iron deficiency anemias, develop over time, This parameter may provide a sensitive indicator of red blood cell size change before the red blood cell indices become overly abnormal. The final item in the CBC is a platelet count, with the normal range of 150 to 450,000. Clinical approach to anemias. Anemia is defined as a reduction in hemoglobin, red blood cells, and hematocrit in a given age group and gender, where reference ranges have been established. Many anemias develop secondary to other conditions, but some result primarily from diseased red blood cells. Patients with moderate anemias, having hemoglobin of 7 to 10 grams per dl, may show few physical symptoms because of the compensatory nature of the bone marrow. When the hemoglobin decreases to less than 7 grams per dl, symptoms invariably develop. Pallor, fatigue, tachycardia, syncope, and hypotension are some of the most common signs of anemia. Pallor and hypotension are associated with decreased blood volume. Fatigue and syncope are associated with decreased oxygen transport, and tachycardia and heart murmur are associated with increased cardiac output. Deeper understanding: erythropoietin. EPO, a hormone secreted by the kidney, functions as a targeted red blood cell growth factor. The bone marrow depends on EPO secretion to support red blood cell production. Conditions such as renal failure, chronic glomerulonephrosis, kidney cancer, chemotherapy, and some chronic diseases may impair the release and function of this vital chemical. Fortunately, EPO is available as a pharmaceutical and can be used judiciously according to circumstance to provide red blood cell equalization. Summary points. Hematopoesis is defined as the production, development, and maturation of all blood cells. Erythropoiesis in the fetus occurs in the yolk sac, spleen, and liver. Erythropoiesis in the adult occurs primarily in the bone marrow. Hematopoiesis within the bone marrow is termed intramedullary hematopoiesis. Outside the bone marrow, it is termed extramedullary hematopoiesis. The bone marrow is one of the largest non-solid organs of the body. The MTE ratio reflects the amount of myeloid elements in the bone marrow compared with the erythroid elements in the bone marrow. Multipotential stem cells can differentiate into non-lymphoid or lymphoid precursor-committed cells. EPO is a hormone produced by the kidneys that regulates erythroid production. Bone marrow aspirate and biopsy are invasive procedures usually performed at the location of the iliac crest in adults. The CBC consists of 9 parameters: white blood cell, red blood cell, hemoglobin, hematocrit, MHC, MCV, MCHC, RDW, and platelet count. The MCV is one of the most stable CBC parameters over time. Increases in MCV can occur as a result of transfusion, reticulocytosis, hyperglycemia, and methotrexate. The RDW may be an early indicator of an anemia. Critical values are values that are outside the reference range and that need to be immediately reported and acted on. The reticulocyte count is the most effective means of assessing red blood cell regeneration in response to anemic stress. Red blood cell production is effective when the bone marrow responds to anemic stress by producing an increased number of reticulocytes and nucleated red blood cells. Ineffective red blood cell production is described as death of red blood cell precursors in the bone marrow before they can be delivered to the peripheral circulation. Morphologic classification of anemias is determined by the red blood cell indices. Microcytic hypochromic anemias are characterized by MCV of less than 80 FL and MCHC of less than 32%. Macrocytic normochromic anemias are characterized by MCV of greater than 100 FL. Normocytic normochromic anemias are characterized by MCV of 80 to 100 FL and MCHC of 32 to 36%. Normal red blood cells are disc-shaped, flexible sacs filled with hemoglobin and having a size of 6 to 8 micrometers. Review questions. The organs of hematopoiesis in fetal life are spleen and liver. The bone marrow responds to anemic stress by expanding production, and red blood cells are released to the circulation prematurely. Cytokines are the chemical substances responsible for differentiation and replication of the pluripotent stem cell. Erythropoietin is the hormone released from the kidney that is unique for erythroid regeneration. The liver and spleen are the organs involved in extramedullary hematopoiesis. The MCV is the most stable parameter of the CBC. The formulate correlation check between hemoglobin and hematocrit used in the rule of 3 is that hemoglobin times 3 equals the hematocrit. The M to E ratio describes the amount of myeloid elements in relation to erythroid elements in the marrow. The reticulocyte count is the most effective means of assessing red blood cell generation in response to anemia.